The authors have no financial interest in any of the products mentioned. Early recognition combined with advances in instrumentation have enabled effective management of PC rupture and vitreous loss during phacoemulsification. PC rupture can occur at any stage of phacoemulsification. For example, during hydrodissection, nucleus removal, cortex removal, posterior capsule vacuuming, and during IOL implantation as well. Failure to manage the PC rupture and the vitreous loss correctly can lead to cystoid macular edema, retinal detachment, secondary glaucoma, and even postoperative endophthalmitis. Surgeons should anticipate PCR in traumatic cataracts, cataracts in post-vitrectomized eyes, posterior polar cataracts, hard brown cataracts, and cataracts with pseudoexfoliation. This animation shows how the vitreous acts like a slinky. In the presence of a PCR with vitreous loss, if a coaxial irrigation and aspiration is used, there can be an extension of the PC rent and increasing hydration of the vitreous. This will lead to vitreous presentation into the anterior chamber. Conversely, using a bimanual irrigation and aspiration or using an AC maintainer, the PC tear gets tamponaded and reduces the amount of vitreous presentation into the anterior chamber. There is minimal hydration of the vitreous, thus allowing the surgeon to do a good anterior vitrectomy and remove the vitreous from the anterior chamber very effectively. Once you have a PC tear with a vitreous loss, there are 4 important points to remember. Number 1 is a vitrectomy cutter, which could be in 20 gauge, 23 gauge, or 25 gauge and should be used appropriately. Number 2 is to use bimanual vitrectomy, that is, have 2 ports, one for infusion and anterior chamber maintenance and one for the cutter. Number 3 is using either a pars plana route or a limbal route. The limbal anterior vitrectomy can be done using 2 separate ports and avoiding the main port, or alternatively, a pars plana anterior vitrectomy can be done. Number 4, use of preservative-free triamcinolone to delineate the anterior vitreous and to facilitate the complete removal of vitreous either through the limbal or pars plana route. This video demonstrates that sudden shallowing of the anterior chamber in the presence of a PCR by pulling out of the eye can cause an extension of the PC rent and vitreous presentation in the anterior chamber. In this case, you can notice there is a nucleus drop as well. This case shows an anterior assisted levitation of a dropped nucleus wherein the nucleus is brought into the anterior chamber and delivered through an enlarged limbal incision. Preservative-free triamcinolone is used to delineate the vitreous and a bimanual anterior vitrectomy is done to clear the anterior chamber of the vitreous, followed by an anterior chamber intraocular lens implant. In this case, a posterior assisted levitation method is used to lift the nucleus into the anterior chamber through the pars plana route using a nucleus rotation rod. The nucleus is then delivered by enlarging the limbal incision. Modern phaco machines have incorporated posterior vitrectomy modules in their softwares. The availability of 23 gauge and 25 gauge vitrectomy cutters have allowed the surgeons to perform anterior vitrectomy through the pars plana sutureless. Trocar and cannula systems have facilitated easy creation of pars plana entry. The ports are created 3.5 mm from the limbus. It's important to keep in mind that the eye has to be sutured and the eye has to be kept firm before making the entry. In case a larger entry is made for a 20 gauge needle, then the port has to be sutured and cannot be left sutureless. This is a case of a posterior polar cataract with PCR due to pre-existing dehiscence in the posterior capsule. Typically, the PCR shows a split end with two pillars of PC, which is very characteristic of a PPC. The nucleus is removed using a bimanual method by maintaining the anterior chamber infusion port separately. A high-density viscoelastic is introduced before removing the phaco probe. A thorough anterior vitrectomy is done and cortex is removed using the bimanual infusion aspiration and cutting. A 3-piece IOL is placed in the sulcus after clearing the anterior chamber. The optic is captured into the capsular excess margin to ensure long-term stability of the intraocular lens. This also prevents the UGH syndrome since the IOL is in the bag. After effective and complete anterior chamber vitrectomy, a foldable IOL can be placed in the bag if the PC rent is small. In large tears, multi-piece intraocular lens with optic capture can be done. In very large rents, a retrofixated iris claw IOL, a glued IOL, or a scleral fixated IOL or an anterior chamber IOL can be performed. PC tear and vitreous loss are not uncommon. They can occur even to experienced surgeons. Anticipation of the PC tear, recognition of the PC tear, and management of vitreous is very important for successful outcome.